We're going to get started on the rest of the endocrine system. So some of this is going to be just in general, and then I'm going to try to break these up into different recordings. So by the time you watch all of them, you'll get all the general information and individual. So I'm going to start with in general, and then this is going to be about diabetes. But just some general things to remember for NCLEX and commonly tested, commonly used information. For insulin, you absolutely need to know peaks and duration because hypoglycemia is a really big consideration. And then remember your mixing rules, that you can only mix regular and NPH, and that we mix clear to cloudy. For steroids, we'll talk about that in our next recording, but important to taper those slowly to avoid adrenal crisis, monitor for infection, and the risk of hyperglycemia. And then for thyroid, which we've already discussed, there is a risk for life-threatening hyperthyroidism or thyrotoxicosis or thyroid storm, which will look like high fever, tachycardia, agitation, and we have to have immediate intervention, which I don't think I mentioned the treatment for that, so I'm going to go ahead and say that generally that just means they're going to be in like an ICU. We'll give them IV fluids, may do like cooling measures in order to bring their temperature down, give some of those anti-thyroid medications. We could potentially give the stable iodine, that Lugol solution, and then manage the effects like tachycardia. We could give them beta blockers in order to bring their heart rate down. Potentially give them steroids, and if it is extreme, they can do plasmapheresis. Okay, so this I just thought was a good image to show you what medications for all of the systems that we give, if there's too little and if there's too much, okay? So if there's too little, obviously we're going to replace it. Medications for that would be levothyroxine, also known as Synthroid, which is literally just synthetic thyroid for hypothyroidism. Somatropin, we'll talk about in the next presentation. That's a growth hormone. Desmopressin is antidiuretic hormone, and then insulin we'll talk about in this presentation, which is secreted by our pancreas. And then hypersecretion means they're too much. We need to either suppress or stop the excess. So the medications for that are methimazole or PTU for the thyroid, and octreotide for the growth hormone. All right, so we're going to get started on diabetes. So there are two different types of diabetes. Type 1 diabetes is when the patient is not making insulin at all. They are not producing insulin. Therefore, if they do not receive supplemental insulin, their body absolutely will not have insulin. This is usually due to their beta cells being destroyed by an autoimmune response. They have to have insulin to live. They cannot receive oral anti-diabetics, okay? For type 1, they have to have insulin. For type 2 diabetes, this generally they have insulin. Their body is producing insulin, but usually this is due to like inadequate diet, or could be caused by medication, and their body just becomes insulin resistant, so the sensitivity to insulin is lost. So they have insulin, but their body just can't use it, or it's not producing enough. So for this type of diabetes, usually the first fix is just try to get them to lose weight. So we'll do diet and exercise, If that doesn't work, they'll start them on oral antidiabetics. Usually they'll start with metformin. And then if sometimes they'll combine and take multiple oral medications to control it, and we'll talk about the different kinds of those. And then if it's uncontrolled, they'll progress to insulin. So that's more progressive treatment. So people with type 2 diabetes could not have to take any medication at all if they are able to control it with diet and exercise, or could only take pills and may never take insulin, or they might take insulin only, or take a combination of oral antidiabetics and insulin. So a little reminder here for type 2, there's few receptors are working. And then hemoglobin A1C, I don't know if y'all learned about that, but when we monitor our labs, glucose is what we are measuring to know what the level of blood sugar we have in our body. And so what is our normal for glucose? Generally, that's 70 to 100. Some people say 70 to 120. Most of the time, especially if you're in a hospital for sliding scale, we're not treating with insulin unless the blood sugar is over 150 most often. The hemoglobin A1C, this is a measure of their glucose balance over like 3 months. So that's going to paint a bit bigger picture of, some people think that they can just take their insulin or take their medication and go to the doctor that day and their blood sugar is going to be low, and they'll say, oh, you've been taking your medicine, even though they haven't been compliant. The hemoglobin A1C is kind of a tattletale. It lets you know over time how their insulin's been controlled, or their blood sugar's been controlled. All right, so this is just a little depiction showing you the onset, peak, and duration. I have another slide of this where it has this information in a table. Onset, peak, and duration are very important for you to remember for the different types of insulin. Why do you think? Because what does insulin do? Insulin gets blood sugar from my bloodstream into my cells, right? And so if that's the case, then I need to know when that's going to happen so that their blood sugar doesn't drop, and so that I'm also looking for signs of hypoglycemia, right? And what do I need to maintain blood sugar? Food, right? So if it's going to have a quick or rapid onset, then I need to make sure that they have food on site, basically. Okay, so food on fork is what I want you to think for rapid acting insulin, which includes Lispro or Aspart. And then for short acting insulin or regular insulin, they need to have it, the food should be on the unit, okay? Because it's going to, the onset of that is within about 30 minutes. So this little mnemonic here, the short staff nurses went from 30 patients to 2 patients in 8 hours. You can remember that the onset for regular insulin is 30 minutes. The peak is in 2 hours, and then it lasts for about 8 hours, okay? So the intermediate, the MPH, the nurses play hero to 2, 8, 16. So that is your time frame for the MPH. And then for long-acting insulin, you can see in the graph here, there's not a peak for that, right? So it just lasts. So a reminder, the long-acting insulin includes glargine or detamir. And your mnemonic or memory aid for that, glargine is larging, and detamir lasts all year. So it's going to just be a steady control. So for long-acting insulin, I want you to think of that as like their baseline. So usually, this isn't all the time, and it really depends on the patient, but usually type 1 diabetics have to have long-acting insulin, because that's going to be like, remember, they don't have it, so we have to give it to them. So we're going to give them insulin, this long-acting insulin that's going to maintain throughout the day and is going to give them a basal or a baseline supply of insulin for that day, okay? Then we're going to monitor their blood sugar. When do we monitor blood sugar? If the person can eat, you're monitoring the blood sugar around the times that they'll eat, right? So usually they're ordered AC and HS, which means what? Before meals and at bedtime, okay? So we gave them their long-acting insulin, and now each time, every 4 to 6 hours usually, you're going to be checking their blood sugar before meals and at bedtime to see if they need an additional, okay? So to cover those specific meals. Now, one thing I'll add here is if a patient has type 1 diabetes, because we know they're going to have insulin, a lot of times they have insulin pumps where their blood sugar can be monitored without having to stick them continuously. And they have a port injected where they can just receive the insulin without having to have a syringe and a needle. So that will be more so for type 1 diabetics because, again, they're going to have it, okay? Very important to know if your patient does have an insulin pump because it could continue to give them insulin depending on what their orders are unless it's turned off. And so if there's a need for it to be turned off, then we need to have an order and we need to make sure that we're turning off that insulin pump where they're not receiving it, okay? Sometimes they can receive additional and sometimes they're just receiving a set amount over time. Really just depends on the patient and the situation again, okay? But knowing that giving your patient food is very important. Helps you know when we're checking it, when to look for those signs and symptoms, and when to hold it, okay? Okay, so here's another little chart that just shows, this might be easier for you to see the differences in the timing and the considerations for those. Again, when you're mixing insulin, we're going to draw up regular first and then the NPH. And then you can remember the role of that or the order of that by remembering RN, so regular, then NPH. I think I have on another slide the caveat to that, and what students often get tripped up with is when you're drawing it up, you remember that you inject air, right? And so you draw up the total amount. Let's say that I need to give 2 units of regular and 4 units of NPH. I would draw up 6 units of air, and then I'm wiping my vials, and I'm going to inject air into the NPH first. Okay, so I'd inject my 4 units of air into the NPH. Then I inject the 2 units of air into the regular, and then I withdraw the insulin from the regular, and then I withdraw from the NPH, okay? The other things here, and these are on another slide, but since I have it in this chart, I'm going to go ahead and explain it. So the VIP for the IV, that means that is referring to regular insulin. Regular insulin is the only insulin that we're going to give IV. And usually if you hear a patient being on an insulin drip, like if they have DKA, that is what they're receiving, regular insulin. And then the lonely dudes, we do not mix long-acting insulins, okay? So I'm not mixing Lantus or Levemir together. I'm not mixing them with NPH. I'm not mixing them with short-acting or rapid-acting insulin, okay? Remember that I'm going to have the food on fork for those rapid-acting, the food on the unit for the regular insulin. Very, very, very important for you to know that you have to have a nurse verify your units. I think I've already talked to y'all about that in the intro to farm information. But I am going to draw it up and I'm going to show another nurse, first of all, what the patient's blood sugar was, what kind of insulin I have, and then how many units I've drawn up. And again, people might be aggravated with you. You want to watch them do that. You want to confirm that, and then you want them to confirm for you. Considerations for insulin, and we'll want to make sure that we're rotating our sites. These can be given sub-Q. So if you have forgotten where sub-Q injections can be given, make sure that you look that up. And then what will we be worried about with giving somebody insulin? Because it is lowering my blood sugar, there is a potential that it could lower it too much, right? And then they're going to develop hypoglycemia. So what does that look like? The way to remember that, the saying is, cool and clammy need some candy, right? So that's going to look like tachycardia, sweating, shakiness, confusion, weakness. They could even be like comatose. They could be unresponsive, which would definitely be an emergency. And that is going to be confirmed by checking their blood sugar via capillary blood glucose or by, why can't I think of the word, like phlebotomy, by drawing their labs. And then another consideration is for something referred to as sick day management. Okay, so when do you think you would hold insulin? Hopefully, you're saying if their blood sugar's low, right? So particularly that rapid or short acting, if their blood sugar's low and they're not eating, then yes, I don't want to give them insulin, right? But it is important to know that when a person is stressed or when they are sick, that their blood sugar is going to be elevated, okay? So even though they may not be eating, or they may need to take insulin, they might need an increased dose. Considerations for long-acting insulin for when you would hold it. The general rule is you're not holding it because they're not going to have insulin without it. Now, if they're throwing up or they're having some sort of procedure and they're not going to be eating for days, potentially we're going off of their blood sugar levels, but that would be an indication that we might not administer insulin. Now, a important consideration: if I tell you that a patient is getting ready to go to surgery, what is an order that you will see when a patient is scheduled for surgery? Most of the time they're going to be NPO, right? So if my patient is NPO for surgery, or the patient is throwing up and their blood sugar is 100, and they have an order, just a standing order, to give them 2 units of insulin every morning, of rapid acting insulin, am I going to give that to them? I hope that you said no, right? Because what is our rule? They have to have food. So I'm not going to give them insulin that's going to drop their blood sugar when I know that they're NPO or that they're vomiting and their blood sugar is just going to get lower. Okay? Hopefully that makes sense. All right, this is just a little depiction. I've already talked about these, so I'm moving on, but this might be a better picture for you. All right, and then here are the golden rules. All right, so we're going to back up just a minute. I've already said this, but I want you to understand it because students really, really struggle with insulin and diabetes. So when you hear diabetes or when you hear blood sugar, just in general, what do you think we're going to do? Most people say we're going to give them insulin, right? But if the blood sugar is low, I'm never, ever, 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 ever going to give the patient insulin because that is going to lower their blood sugar further, okay? So let's just recap, what does insulin do? It's going to lower our blood sugar, right? And how does it do that? It pushes sugar into the cells and out of the bloodstream. So we're going to think of insulin as the car that drives the sugar into cells, okay? So our bloodstream could be full of sugar, full of it. It could have every ounce of sugar it could ever want. But if there is no insulin, then the cells are not going to have the sugar that they need to function, okay? And the patient can have severe complications. And what is that called? So that is DKA or HHS. Now, I want you to also remember that insulin plays a role in getting potassium into the cell. So you can think of potassium as a passenger in the car that drives the sugar into the cells, okay? So potassium's also getting into the cell. So the biggest risk for giving insulin, what do you think? It's hypoglycemia, right? Especially at that onset of the administration. Okay, so remember that during that window, whenever that is, depending on the type of insulin, the patient needs food. So if I'm going to talk about this on another slide, but I want you to be thinking of before then what we would do if a patient's blood sugar is low. Okay, what we're going to do for them. Okay, remember that the regular insulin is the only thing we're given IV. Remember our mixing order. Remember we're not mixing the long-acting insulins. Remember that they might need increased insulin due to stress or illness. Remember to rotate your sites. Remember that long-acting insulin can be given without regard to meals, and that we need to monitor for hypokalemia because of that relationship with potassium. All right, so I wanted to put these pictures here because this is also an important consideration with insulin. So on the left, I have a lot of different needles, okay? And then I have a picture in the middle and a picture on the right. So I want you to just look at this for a second and tell me what syringe you would use to pull up 4 units of insulin. You can pause if you need to. And then I want you to think about what you would use if you were given 75 units of insulin. Okay, so the ones on the left, we're not using those at all, okay? Insulin syringes are specific to insulin, and they are marked in units, okay? All of these other syringes are milliliters, so we're not using that. So you can use, for the ones in the middle, you can see that the units go up to 50. You can't really see that, but the ones on the right, the units go up to 100, okay? So for, and I can tell they're insulin syringes because of the orange cap, okay? So for the less, if I'm given up to 50, I would want these 50 units because they're spaced out a little more and it's easier to be more exact. If I'm given over 50, I would want these 100. Now, sometimes you only have access to either or, and that's just dependent on the facility. But remember, you have to use the insulin syringe. Okay, now we're moving on to oral anti-diabetic. So who am I giving these to? Type 1 or type 2? Type 2, right? Because type 1 can only use insulin. So there's different classifications of these drugs, and again, they may only take one or they may take a combination. It just depends on the patient and how well their blood sugar is being managed. All right, so biguanide, a common medication in that class is metformin, and it works by decreasing the synthesis of glucose in the liver. Risk of that is it causes GI upset. There is a high risk of lactic acidosis, and very, very, very important to know that you have to hold metformin between 24 and 48 hours if the patient is having a procedure where they're getting IV contrast, okay? And then there are alpha glucoside inhibitors. The drug there is acarbose, so it prevents carbs from being absorbed. It can cause severe GI distress, so it's contraindicated in inflammatory bowel disease. Other drugs, sulfonylureas, one of the drugs in that class is glipizide. It causes the release of more insulin. There is a risk for weight gain and hypoglycemia with those. And then thiazolidinediones, I do not know how to say that word. And a drug in that class is pioglitazone, and it increases tissue sensitivity to insulin. There is a risk for fluid retention, so we absolutely do not want to give those to patients with congestive heart failure. All right, so this is kind of just a repeat, but I'll go over a few other things. So for metformin, again, this is usually the first line treatment for type 2 diabetes. Increases insulin sensitivity and decreases glucose production in the liver and intestinal absorption of glucose. Usually it's given with morning and evening meals. Remember, we're going to hold it for that IV contrast because there's a risk for renal failure and lactic acidosis. For the sulfonylureas, other drugs, there's glipizide, glimepiride, or globuride. You can remember that by that "ide" at the end. They cause the pancreatic beta cells to release more insulin and reduce glucose output by the liver. Usually these are given 30 minutes before the morning meal if they're given once daily, or 30 minutes before morning and evening meals if they're given twice daily. We want to monitor closely for hypoglycemia and weight gain. Important to know with these is if they have a sulfa allergy, which is a fairly common allergy that goes across a lot of different types of drugs, but you can remember that by the sulf in the sulfonylurea, that this would be contraindicated. Another consideration, they can cause an antabuse reaction if they're mixed with alcohol. So antabuse is a medication given to patients who alcoholics, and it causes a violent, like, vomiting if they consume alcohol while taking it. So it can have that same effect if the patient takes alcohol, so make sure to tell them to avoid that. All right, and then I've talked about the other one. All right, so the those TZDs, that word I can't say. Remember the black box warning for heart failure. So we want to make sure that we're monitoring for peripheral edema and crackles, and they would need to stop that medication if they develop that. We also need to make sure that we're monitoring liver enzymes, taking baseline, and monitoring every 2 months when they start this medication. The SGLT2 inhibitors, that stands for sodium glucose cotransport. The drugs in that class end in the gliflozin. So canagliflozin, gosh, that's terrible. They make the kidneys excrete glucose through urine, and they can slow the breakdown of intestinal hormones that cause insulin levels to increase after a meal. So these are taken before meals. Because they're excreting urine, excreting glucose through the urine, there is a high risk for UTIs or vaginal yeast infections. and polyuria. So we want to make sure that we're teaching our patients to report UTI symptoms or itching, burning for vaginal yeast infections. Okay, and then those GLP-1 agonists and the DPP-4s, those end in the tide or gliptin. A common drug is semaglutide. These work by mimicking incretin and slowing gastric emptying. They increase satiety, which is just that feeling of fullness, and then increase insulin release. There is a risk for pancreatitis, GI issues, and there's a black box warning for medullary thyroid carcinoma. So those are becoming more common and, in my opinion, even being abused by people who are trying to lose weight, like think Ozempic. And so very important that people realize the potential complications for that and know how to recognize pancreatitis or thyroid issues, and also realize that those are not a replacement for insulin for people who are insulin dependent. Giving somebody something to lower their blood sugar, what would I be worried about? It getting too low, right? So hypoglycemia is a risk. And what do you do if their blood sugar is low, if they develop hypoglycemia? So I go in to check on my patient, their heart rate's high, I can notice sweat on their forehead, they're shaky, maybe they're confused and I can't understand what they're saying, maybe they're passed out. What would I do? What do they need? They need sugar, right? And so have any of you ever felt like that? Have you felt like your heart's racing, felt a little shaky because you hadn't eaten? And what do? You usually eat, right? So that's what they need. They need sugar. So if they're awake, then I would just want to give them some sugar. The rule is that I want to give them 15 grams of simple carbs. So candy, juice, whatever, okay? Followed by more complex carbs because it needs to be sustained, right? What if the patient is passed out? Am I going to shove juice down their throat? Please no, because I don't need them to aspirate, right? So we can give them IM glucagon. The little memory aid here is when glucose is all gone, give glucagon. Or we can stab. I hate that, but maybe it'll help you remember it. With D50, which is 50% dextrose. Okay. Always, always, always going to reassess in 15 minutes after we're treating because we might have to do it again. Okay. If their sugar hasn't been sustained. The flip side of that, if we're not doing enough or we're not treating it, is that they could have hyperglycemia, okay? And the little memory aid for that is hot and dry, the sugar's high. Key things to remember for recognizing hyperglycemia is polyuria, polydipsia, polyphagia. What does that mean? So they're peeing a lot, they're thirsty, and they're hungry, right? Okay. This is just another way for y'all to remember what I just said. So we're moving on. Okay, I wanted to put some pictures in here to hopefully help you understand, especially maybe if you haven't seen some of these things. So on the left-hand side is glucagon. This is something that is potentially you could be giving, where it has instructions here for you to draw this up and administer glucagon IM. On the right up top, that is a glucose gel. So it's just something you put in their mouth, squirt it, or they can put it in their own mouth. We have candy, we have juice, and then those glucose tablets here. Okay, and you see that it says there's 15 grams of glucose in those. So even if they're at home, we're telling them to take this, and then in 15 minutes they need to reassess, and then they need a complex carb in the meantime, after they take it, after they're stable, okay? Even if I have to give them glucagon or dextrose, once they are alert, then I need to give them a complex carb, okay? We're not done just because I've gave them D50. And we're reassessing. Now, what do I do if the person can't eat and I just gave them D50 to bring their blood sugar up? Then we're going to give them a dextrose infusion, right? So they'll probably have like D10 in a continuous IV. Okay, this is just different variations of what D50 or 50% dextrose looks like, okay? Now I want to tell y'all a story. So I had some students on a unit, and we went into we had just got there, and we're looking for nurses and can't find them anywhere. And I go into the patient's room, and there's about 6 nurses standing around the patient's bedside, and they are freaking out. And I'm like, what's going on? Do y'all need some help? And they said, his blood sugar is 48. And I said, oh no. And they said, he doesn't have an IV. We can't give him D50. We can't find a vein. And I look at this guy, and he is sitting up in the bed looking at me. And I said, sir, do you think you can swallow? And he said, yeah, I think so. You don't have to give D50. This is kind of an option. Kind of even think of it as last resort, right? If the patient can swallow, we just need to get them sugar. This is just a tool that you could have if they can't swallow, okay? But if you've never seen these, they can be kind of tricky. Most of the time, they come like in this bottom left corner. They'll come in the box like what's up top on the left. And then the bottom left corner is what it looks like in the box. And then you see those instructions in the top left. It shows you how to screw it together, and then you push it. Now, usually the order will say like an amp of D50 is what you're giving. And what that means is this whole thing, okay? Either this glass vial that you see or one of these injection tubes that are already contained. Now, I want to tell you, what is dextrose, first of all? It's sugar, right? So it's very thick. And so when you try to push this, it's hard. It is hard to push it because it's thick. And so just know that. And you are trying to push it as quickly as you can, but it is going to be hard to push, okay? All right, and we're going to stop there.